Our next presenter, I am so honored and pleased that he can join us. Perhaps the one who has traveled the farthest, all the way from Greece, right? Dr. Christos Sidiropoulos is a movement disorder specialist that also practices out of Michigan State University. Yes, right? And he's just a wonderful, wonderful doctor, and I've been very fortunate to know him for a very long time. So please welcome Dr. Christos Sidiropoulos.
Thank you, Julia. Okay. Thank you. Well, thank you very much, Julia. Actually, Julia has known me since I was a resident and has been instrumental in me choosing movement disorders as a career path. And thank you very much for the honor of being here and spending some time with you and talking about a very important topic, namely what's going on in terms of treatment. It's an honor and a pleasure to be among you. Thank you very much for inviting me. And I'm going to be talking about what's out there in terms of treatment options. So here are my disclosures. Again, acknowledgments to one of my mentors, Dr. Peter Lewitt, who I used to work with when I was a resident at Henry Ford. He has allowed me to use some of his slides. Unfortunately, he has not been able to be among us today. And here are the objectives of the presentation. Basically, we're going to talk about what has just been approved for Parkinson's disease. So what is already available or just has been available for Parkinson's disease. Talk about the pathobiology of the condition. So this will help us understand what is going on in terms of developments. I mean, where is research heading towards? Talk about updates, what's coming up in the next very few years, and what will come up in the next 5 to 10 years from now. So as you all know, Parkinson's disease is a very common disorder. It's very common. Some people say it's about 1% for folks above age 65. Statistics vary, maybe up to 3%. It's over 1 million people in the United States, 1.2 in Europe. It's a condition that imposes a huge socioeconomic burden on all countries, all over the globe. And we know when we lose like 50 to 60% of our dopamine-producing cells, then we start having, motor symptoms. The mainstay of treatment is through medications that replenish dopamine, which is, the chemical missing in Parkinson's disease. However, as the condition progresses, we tend to lose more and more of those cells, and other neurotransmitter systems get involved, like serotonin and noradrenaline, and we need to deploy more strategies to adequately address symptoms. You see here the chronology of symptomatic treatments for Parkinson's disease. It started like over 200 years ago with Dr. Parkinson, who described the condition. Initially, we had anticholinergic medications that we don't use that often today because they can cause sedation and constipation and all of other issues. The first true revolution in the therapy of Parkinson's disease was the introduction of levodopa in the 60s. We all know that is the well-known Sinemet. And as years progressed, other medications came to be used, like amantadine that we know very well, the carbidopa that is used along with levodopa and reduces nausea and other side effects. Then dopamine agonist came, other medications like selegiline and rasagiline, and later there were other efforts like gene therapy over the years, and we come to the 2015 with approval of Rytary and Duopa, like a pump that uses essentially a feeding tube to deliver liquid levodopa into the gut, other medications like istradefenil or Ongentys, and then 2024 and 2025, just a couple months ago, we have seen a lot of stuff like happening in Parkinson's disease treatment and therapeutics with some very important developments, and we're going to talk about that, namely the approval of Crexont, Vyalev, and Anapco. So very briefly, Crexont is a product that essentially delivers levodopa to the system. It's like a better formulation of levodopa consisting of immediate and extended release. It seems to last longer than the usual levodopa formulations. It gives patients approximately half an hour more on time, on average, during the day, and each dose may last up to 1.5 hours longer compared to standard treatment. So that's a major development. Again, still levodopa, nothing tremendously different, but a new way of improving the availability of levodopa. So that was like a very welcome development. This was the study that led to the approval of Crexont, basically, again, more on time during the day and 1.5 hours perhaps more on time per dose. The other new kid on the block was Vyalev by AbbVie, essentially a pump that delivers subcutaneously. That means through a fine needle under the skin, levodopa for 24 hours. And this is a less invasive, clearly a less invasive way of delivering levodopa. Studies showed that it may give patients 1.75 hours more on time compared to immediate release levodopa. That means patients, compared to the standard treatment of immediate release levodopa, have, I would say, about 2 hours more on time per day. Again, that shows it's a good effect, a robust effect compared to immediate release levodopa, and gives people more sustained benefit during the day. Now, this was the study. Briefly, I want to show you here for maybe, it's not that easy to be seen, but some important take-home messages apart from the about 2 hours more on time per day is the fact that, like every pump that uses delivery, subcutaneous delivery, we have skin nodules as a common side effect, and a considerable proportion of patients who were enrolled in this study dropped out because of skin nodules and skin reactions, so about 22%. So keep that in mind. Very robust, good treatment, but it's not a perfect one like with every treatment that we have for Parkinson's disease. And this is another study with another pump that is being tested, has not been approved, but it shows similar efficacy as compared to the Vyalev. This is another product by another company called Neuroderm. Has not yet been approved, but essentially it shows very similar efficacy to what the approved pump shows. So another very welcome addition to our arsenal against Parkinson's disease is the pump called Anapco, the subcutaneous delivery of apomorphine. Apomorphine is a medication that has been around for decades for the treatment of Parkinson's disease as an intermittent subcutaneous injection using a pen. And this is a very good option for folks who have off time or freezing of gait. This actual pump has been available in Europe for decades now, and unfortunately, it took us a long time to get it approved here in the States. It uses continuous for 16 hours delivery of apomorphine, and the study that I'm going to show to you showed approximately, again, 2 hours reduction in off time compared to placebo. And this is the study. Again, off time improved a little bit less than 2 hours, so very comparable results to the other pumps that I showed you. Again, skin nodules is another side effect, not uncommon at all. And this is a very interesting paper that essentially compares a variety of pumps that are available. One pump that is shown here in this paper is a pump that is mostly used in Sweden and is not available in the United States and in the rest of Europe. Long story short, most of those pumps show an improvement of about 2 hours in terms of off time. Off time is how much time patients are not, functioning well. Medications don't kick in very well. In the bottom part of the slide here, you see the Duopa pump, essentially, the feeding tube, the pump that uses a feeding tube to deliver liquid levodopa into the intestine. So we have good improvement with all those pumps. It is a fortune, it's a good thing that we just got 2 pumps approved in the United States in the last few months. So those things were just became available. The question is, how does this whole problem begin? How does Parkinson's disease begin? So the answer is we don't know exactly how, but we're starting to get there. So it seems that a variety of outside factors like environmental, like we talked about toxins, heavy metals, we talked about TEC, and other products that may increase the risk for development of Parkinson's disease, as well as genetic factors, aging. All those factors seem to converge and may cause a variety of changes at the cellular level in our brains. I mean, those changes may have to do with aggregation of a protein called alpha-synuclein, may have to do with dysfunction of mitochondria, which are the energy-producing organelles in our cells, or lysosomes, which have to do with scavenging junk protein in our brain, in our whole body, may have to do with increasing inflammation. So there is a variety of mechanisms that are involved in the development of Parkinson's disease. And if we look at the cells, there might be, accumulation of, a variety of proteins like alpha-synuclein, as we said. You see the alpha amyloid protein that we have been talking about as far as Alzheimer's disease is concerned. And we see also that different treatment strategies that are being developed right now may target either the alpha-synuclein, which by many is thought to be, playing a key role in the development of Parkinson's disease. Other strategies are targeting lysosomes. That means those organelles that have to do with scavenging junk proteins. Other strategies are targeted towards mitochondrial dysfunction. So you will see that there's a lot of going on, and a lot of areas are being researched, and a lot of different targets are being aimed at in Parkinson's disease. So, and also it's the gut-brain axis that you see here. There is a lot of discussion about where, not exactly when or how, but where does it start. So there is a lot of evidence that it may start actually in the gut and propagate upstairs through the so-called enteric nervous system, and essentially go up to the brain, or start in the olfactory bulb in the brain and then propagate the opposite way towards the gut. And you will see that later that a lot of drugs that are being researched have to do with the gut-brain axis, as we were going to talk about it in the next couple of minutes. And you see this is the trajectory of Parkinson's disease. It may start anywhere between 10 to 20 years as a prodromal phase before actually the onset of motor symptoms, as constipation, like REM sleep behavior disorder, dysfunction in the sense of smell, and as years go by, you see the onset of subtle motor impairments, mild shake, slowness, stiffness, and then you see other features kick in like apathy, fatigue, the so-called motor and no motor fluctuations, dementia, psychosis, and so on. So this is a multifaceted disease, and you will see that a variety of strategies are being developed to tackle not only the motor aspects of the disease, but also the non-motor aspects, which are also more difficult actually to properly deal with. And the other interesting thing, because it helps us understand how difficult and multifaceted this condition is that Parkinson's disease has a variety of subtypes. As we said, every patient is completely different. There is not one disease or one condition. It is a syndrome with multiple manifestations. There are patients who have more shakes, then they're called like patients who have tremor-dominant Parkinson's disease, patients who are more stiff and rigid. They have the so-called postural instability and gait difficulty form of Parkinson's disease, and you see that dopamine mostly controls the motor symptoms, but the other neurotransmitters may affect other motor and non-motor manifestations. So it's really a host of symptoms and a host of neurotransmitters that are involved, and definitely this makes the whole thing more complex, but you'll see there is a lot of hope and a lot of stuff going on in terms of therapeutics. So the emerging therapies for Parkinson's disease that are being developed are targeted both at motor and non-motor symptoms, and those are what we call symptomatic therapies, but also disease-modifying therapies, which is the holy grail of neurodegeneration, including Parkinson's disease, and those include both medications, cell and gene-based therapies, and other therapies. And this is a slide taken from a paper that is a little bit older than a year, and you see a lot of stuff happening. This gives you like an overview of what's happening in the in our world, in the Parkinson's disease research world. You see a lot of disease-modifying therapies right now in development and symptomatic therapies, and you will see that only a few of them are entering phase 3. Therefore, I wanted to remind everybody the phases of a clinical trial. We have the phase 1 trials. Those are the early trials, the trials that recruit a small number of participants. They mostly assess the safety of a new drug. Then we have phase 2 trials that may involve a couple of tens to a few hundred patients, and they assess safety and efficacy. And then we have phase 3 trials, which are the trials that companies use to file for approval of a drug. And as you see here, it may take well up to a decade actually for a drug to start being developed until it gets approval. So you see how difficult it is for a drug to get approved, and actually this is to some degree a good thing, because we want to, first of all, to assess the safety of a medication, but you also understand why so few of those drugs essentially enter phase 3. So it's important for all of us to understand, the difficulties of producing safe and efficacious new therapies. And, the quest for disease modification came initially with some frustration, a lot of trials, mostly by the Parkinson study group. You see here in the late, about five years ago, many of those trials came back negative. But now the new important wave of treatment trials have to do with anti-alpha-synuclein approaches, as we're going to discuss. Again, alpha-synuclein is abundant in our nerve cells. Its functions are not entirely known, but there seems to be involvement of an alpha-synuclein in Parkinson's disease. Many, but not all, Parkinson patients have the so-called Lewy bodies. You have heard about them. And Lewy bodies are mostly made of alpha-synuclein. And you'll see other approaches using glycagon-like peptide-1 receptor agonists. Those are basically injectable diabetes drugs, and they are being tested for a variety of conditions right now besides diabetes. They also are used for weight loss, but they seem to exert a lot of good properties, including anti-inflammatory properties. So in this slide, you see what I was talking about. There has been a shift towards clearing alpha-synuclein from the brains of patients with Parkinson's disease. Many trials right now are underway using either what we call active immunization, that means a vaccine, or passive immunization, that means delivering antibodies to clear alpha-synuclein in a variety of forms, either in the forms of oligomers or in the forms of fibrils, that means like bigger clumps of alpha-synuclein. And as you see here in this slide, this is like essentially a summary of all of all the trials that are being going on right now, targeting alpha-synuclein. Again, there is a very, very vivid scientific discussion whether this is the right way to do it. And this essentially follows the paradigm of monoclonal antibodies for Alzheimer's disease. So it's pretty much, the same rationale, trying to get rid of a junk protein that, it will restore brain function. So this is, pretty much the same thought process. And recently, two trials, the results of two trials get published in the New England Journal of Medicine, which is considered a very, very, very credible scientific journal, using two monoclonal antibodies, prasinezumab and cinpanemab, that were meant to clear alpha-synuclein from the brains of patients with Parkinson's disease. Again, it's a very similar thought process and paradigm to Alzheimer's disease and the recently approved monoclonal antibodies. So basically, you're going to be, intimidated by this slide. What I wanted to show you here is the curves, the two curves. The curves of placebo, that means the patients who received non-active drug and active drug, they're like next to each other. Long story short, it shows actually there is no benefit. So basically both studies, disappointingly, showed no benefit. So that was like something that was disappointing, not expected. However, a secondary analysis of the trial that used prasinezumab and also a comparison to historical cohorts of patients showed some hint towards efficacy. So I would say, this story is not over yet, despite disappointing results. So prasinezumab is still under investigation for its potential disease-modifying properties. So there's a lot of discussion. What are the next steps are going to be? There are also other approaches against alpha-synuclein, because it's much easier to have like an oral molecule or like a pill to swallow and get rid of alpha-synuclein. You'll see here a variety of medications or drugs being investigated with very weird names. What I wanted to show you here is that there is a lot of research towards, alpha-synuclein approaches going on. And even other studies are looking at molecules that clear alpha-synuclein from the gut, because there is a thought process that accumulation of alpha-synuclein in the gut not only will make the alpha-synuclein propagate through the gut nerves to the brain, but may also cause a very common problem of Parkinson's disease, namely constipation. So there was like a small study that showed that a molecule against alpha-synuclein helped Parkinson's disease constipation, but obviously, this product is still under development. It has not been approved. So this was a very interesting trial published about a year ago, again in this very, very credible journal, the New England Journal of Medicine. Most of us who are neurologists know that and respect that journal extremely well, and used a product called lixisenatide, which is an anti-diabetes drug, in patients with early Parkinson's disease. Again, the thought process was disease modification, because it is thought that those molecules, the GLP-1 receptor agonist molecules, drugs that we use for diabetes, may also exert a variety of good properties, reducing inflammation, producing disease modification, perhaps in Parkinson's disease. And those molecules have been under investigation for over a decade now. So this study, although it did not clearly met its primary endpoint, that means it did not clearly and without any doubt showed efficacy, it showed a hint. So patients in this study showed over 12 months a smaller degree of deterioration. So again, this means that we need further investigations with this type of drugs. And as you will see here, this is also a paper that Dr. Okun was involved in. This is a population study which basically took patients who had type 2 diabetes and were taking either the GLP-1 receptor agonist drugs and another class of drugs called DPP-4 drugs. So basically, the patients who were on those GLP-1 receptor agonists, they seemed to have a lower risk of developing Parkinson's disease. Again, those were like diabetic patients who got put on 2 different classes of drugs, and the ones who were on those GLP-1 receptor agonist drugs, they seem to have a lower risk of developing Parkinson's disease. So does this truly prove the point? No, but it shows something that those products perhaps need to be further investigated, and right now there are phase 2 trials using similar products called liraglutide and semaglutide. Unfortunately, recently another trial in the United Kingdom called exenatide PD3 was a negative trial, didn't meet its endpoints, but again, we want to truly investigate this further. This seems to be a signal towards doing something good and positive for patients with Parkinson's disease. So LRRK2 is a gene that may account for anywhere between 2 to 7% of patients with Parkinson's disease. Keep in mind, if you do genetic testing in Parkinson patients, you will find anywhere between 10 to 15% of those patients, of Parkinson patients, having some sort of genetic mutation that is responsible for their Parkinson's disease. Now, does this mean that this percentage will not change in the future? No. The more we're testing, the more we're learning about genetics of Parkinson's disease, and I do encourage all of you to consider enrolling in trials that offer free genetic testing. So this molecule, actually, this gene that codes for LRRK2 has been an active target of investigation. A variety of phase 1 and 2 trials are currently underway. Either small molecules or genetic treatments are being developed with the small molecules, with oral pills. There seems to be a class effect that in terms of side effects, namely headache. The next few years will show the real clinical value of this class of drugs. So that's another target for treatment for Parkinson's disease patients. Here, the interesting thing is that it seems that this avenue potentially could work not only for patients who have a pathogenic mutation, but also for patients who actually show increased activity of this enzyme. So even patients who don't have a mutation, but for a variety of reasons, show an increased activity of LRRK2. This is a world map that shows the distribution of another gene that is very commonly associated with Parkinson's disease, namely GBA. So GBA1, that gene codes for an enzyme called glycocerebrosidase. This has to do with the proper function of lysosomes. Again, lysosomes are the small parts of the cells that have to do with scavenging of junk protein. So anywhere between 5 to 15% of patients with Parkinson's disease harbor a mutation. This is, as I said, another target of active investigation. An agent called ambroxol that is used in cough syrups has been shown to improve the activity of this enzyme and hence restore to some degree its normal function. It seems to also demonstrate anti-inflammatory properties, and there are many trials right now using ambroxol, this ingredient of cough syrups. So many trials currently using ambroxol to assess its efficacy in Parkinson's disease, and also gene therapy approaches under development in the same way as we discussed for LRRK2. And additional approaches for restoring the proper function of lysosomes, like some more fancy stuff over here in preclinical studies, not in clinical studies. That means in animal models. Again, a little bit confusing, but I want to show you that there's a lot of active stuff going on towards restoring function of lysosomes. Other approaches towards restoration of mitochondrial function. Mitochondria are the parts of the cells that produce energy. Some patients harboring specific mutations like Parkin and Pink mutations have mitochondrial dysfunction. Hence, there are some studies worldwide and also in Europe utilizing a variety of agents like vitamin B3, etc. So changing gears now, and we're going to talk about something that a lot of people may have questions on or very very strong interest in, is the cell and gene-based therapies. So cell therapies are a variety of therapies that may use a variety of forms of stem cells, and we're going to talk about that. Gene therapies are therapies that are trying to restore lost gene function, and this happens through a delivery through a viral vector of a gene for enhancing either dopamine availability or enhancing neurotrophic factor availability or restoring damaged circuitry. And you can deliver those either cells or genes through intrathecal, like a spinal tap, or through the blood vessels, or through the nose, or actually through a catheter through a hole in the head. So there is a potential for disease modification if we use those therapies. Those therapies are trying actually to slow down Parkinson's disease and not just symptom control. And there's a lot of studies at this juncture happening, investigating both stem cells and gene therapies. Now, all those therapies, however, are to some degree invasive, and there are some issues. I mean, especially for stem cells, there might be the potential for either tumor formation, cell migration, delivering the right amount of cells or genes to the right part of the brain, okay? Surgical complications like infection, brain bleed, immune rejection. Oftentimes, patients who enroll in those trials have to undergo immunosuppression so the graft doesn't get rejected. It's like having a transplant, basically. Getting across the blood-brain barrier. Remember, if you get a drug, it doesn't easily cross that barrier in your blood-brain blood vessels. It doesn't easily get into your brain. Focused ultrasound may be a modality to open up the blood-brain barrier and allow for delivery of medications or stem cells or genes through the brain blood vessels. And in this paper, you'll see what is the origin of the stem cells. Stem cells may emanate from bone marrow, from teeth, from adipose tissue, may come actually from your own stem cells, which or fibroblasts from skin cells. A very interesting approach is taking your own skin cells and then reprogramming them so that they turn into actual stem cells, and this bypasses the need for immunosuppression. So there is a variety of origins of those stem cells, and you will see here a host of clinical trials mostly in animal models using cellular therapies. And in this slide, you will see a variety of trials right now in humans. So right now, there's a lot of stuff going on in terms of cell therapies, both in the United States and worldwide. Those are like small clinical trials, obviously, because there is a lot of difficulties assessing safety and efficacy. And they use either what we call autologous stem cells. That means stem cells that essentially come from one's own body, or allogeneic stem cells. That means they have been harvested from another donor, or fetal stem cells, etc. So this is an overview of some particular studies going on, like the one by Blue Rock Therapeutics. This uses delivery of dopamine-producing embryonic stem cells in the putamen. The putamen is a part of the brain that is part of the basal ganglia that is, affected in Parkinson's disease. That means there is delivery through a catheter and through a hole in the skull, actually, of dopamine-producing stem cells. There is a need in this study for immunosuppression for 1 year, as we discussed. The initial results have been promising. It's entering phase 3. That means, the phase prior to potential approval of the product. Another study called STEM-PD in the UK and Sweden, where all surgeries are undertaken in Sweden, is going on. Another study by Aspen Therapeutics which uses this very interesting approach. Essentially, stem cells, actually skin cells, are harvested, then reprogrammed. They become what we call induced pluripotent stem cells, and they're again injected back to one's own body. Is currently recruiting patients, and there is no need for immunosuppression in this study. And this is another very interesting paper that came back just a few months after the former one that I showed you, that summarizes all the the treatment trials utilizing cell-based therapies. That shows basically that there is a lot of stuff going on in terms of stem cell trials, and there is a lot of optimism that those trials may come to, at least some of them may come to fruition, because they may offer the potential for disease modification and disease slowing down. So, talking briefly about gene-based therapies, that means delivering not actually a cell or cells or stem cells, but delivering through a viral vector of delivering genes that restore normal circuits in the brain. There's, again, a lot of things going on, like the AB1005 study, where the gene for a trophic factor called GDNF is delivered again into the putamen, which is a common target of those cell or gene-based trials. Phase 1 study showed good tolerance of the product. Now it's entering phase 2 in the United States and in the European Union. Another study using GAD, another gene, GAD, glutamic acid decarboxylase, is entering again phase 2 and 3. The initial trials were actually undertaken in the United States several years ago, but because of financial problems of the company that essentially developed the product, they came to a halt. But now this approach is being revived. Another study using GBA1 gene approaches is underway and entering phase 2. So, in summary, as far as the cell and gene-based therapies are concerned, they offer great opportunities for disease modification. But what is the problem? There are many difficulties to overcome as far as to how safe they are, how effective they are, what's going on in terms of tolerability, logistics, and essentially applicability to the broader Parkinson's disease community. Because as you understand, those are treatments that cannot easily be applied to, thousands or tens of thousands or hundreds of thousands of Parkinson patients at once. And of course, costs. And in my opinion, those approaches are great and need to be further pursued. And they might be ready for prime time in 5 or 10 years from now, but probably for select candidates. Probably for candidates who have maybe a very specific genetic mutation, for instance. Again, changing gears towards symptomatic therapy is one of the common issues that Parkinson patients face are levodopa-induced dyskinesias. A phase 2 trial using the anesthetic agent ketamine has been suspended, but there are other trials using new molecules because, as you know very well, there are not many drugs that ameliorate dyskinesia. I mean, basically we have only amantadine and a variety of amantadine formulations to calm down dyskinesias. So there are some products being investigated, like a product by Bhagwan Therapeutics, which is in phase 2, and another product called mesdopetam, which has entered phase 3 and hopefully could get approved so we can have more treatment options for levodopa-induced dyskinesias. Another product that is being investigated, it's also likely to be approved, is a product called tavapadone. That's the name of the dopamine agonist. As you know, we have only a limited number of dopamine agonists available for Parkinson patients, and this is a dopamine agonist that targets different receptors than the usual dopamine agonists that we have nowadays, namely the D1 and D5 receptors. So there seems to be good hope that this can also be approved and seemed in the clinical studies to give good results. And converging to the common denominator of our whole symposium today is what are some further perspectives about Parkinson's disease. So could there be any prevention strategies? And what about exercise and diet? So basically, you heard it multiple times, and I'm sorry to be, perhaps preaching to the choir and saying the same stuff again and again, but exercise, exercise, exercise. The effect of exercise, and there is a lot of literature to support that, is so beneficial in Parkinson's disease, and it seems to be mediated by restoring dopamine, to some degree, dopamine production, improving the production of neurotrophic factors, reducing cell death, and reducing inflammation in the brain. So, I mean, I know it's a busy slide, but basically what it tells you is exercise does a lot of good stuff to your brain. And another way of doing that, or another avenue of doing that, is by having your muscle produce a molecule called irisin, and there has been a lot of research towards that molecule. Many think of it as the holy grail of neurodegeneration. It seems to be reducing the clumping and aggregation of alpha-synuclein, reducing inflammation. So a lot of research has been geared towards investigating further the role of irisin, which is like a protein that gets released by your muscles when you exercise. So does exercise only help motor symptoms? No, it does help also the way your brain thinks and functions, and it helps your memory. So this was a great paper by my esteemed colleague and friend, Dr. Mahajan, that basically what it showed is that exercise improved cognition in patients with Parkinson's disease, and it does so in a dose-dependent manner. What does it mean? It means the more you exercise, the better you do. And what does it also mean? That instead of doing nothing, at least do something, even a little bit. Even that is beneficial compared to doing absolutely nothing. And what about diet? There is an increased amount of literature that also supports the role of Mediterranean diet and healthy diet in general in preventing the development of Parkinson's disease, but I will say also, in my opinion, also in improving the overall function of patients who already have Parkinson's disease. So a healthy diet, maybe also using probiotics, maybe reducing also constipation, may help patients who already have Parkinson's disease. And just another interesting aspect of therapeutics, there have been some studies with transplantation of fecal material. That means with material that has, healthy, microbes, healthy gut bacteria. The studies have been inconclusive, but again, this goes back to the discussion of the gut-brain axis, that maybe by restoring the normal bacterial population in the gut of patients with Parkinson's disease, which we know is changed and altered in Parkinson's disease, may offer some therapeutic benefit. Again, studies are mixed. We're not there yet, but I just wanted to show you this interesting approach. So I know you're getting kind of sleepy. It's afternoon, sleepy and yawning, and everybody's exhausted. So I wanted to close by saying here that Parkinson's disease is a very common disorder. Truly, it's basically a spectrum. It truly deserves a short, mid, and long-term plan to address it. So new medicinal and non-medicinal products, and I have to say here, there was essentially no time to discuss neuromodulation strategies like deep brain stimulation, etc. So I focused my discussion today on medication and related strategies to deal with Parkinson's disease for the cost of time. So new products are being approved, many others are being tested, are under development. But treatment actually begins with awareness and proper prevention strategies before actual neurodegeneration occurs. And here is the need for biomarkers. That means for ways either through skin biopsies or blood tests or MRIs to detect potential patients or detect patients or detect folks who are going to develop Parkinson's disease early on, and then apply prevention strategies. Therefore, we need individualized and targeted approaches, and of course, we need to keep smiling and exercising. And with that, I would like to thank you for your attention.